Thank you to Dr. Shen and Dr. Choi for inviting me. It's truly an honor to be here. And now I have two really hard acts to follow. And I have about 20 minutes. And this is a pretty big topic. So I will not talk about all of my slides. But I'll talk about approaches to treatment. I'm a clinician and I treat patients. I would say that all treatments for addiction are underutilized. So I'm hoping this audience can help. And I'm going to kind of briefly breeze through a lot of things. So we've heard addiction's a brain disorder. I'm not going to talk about that any further. When we're approaching addiction with patients, first we have to detox people. I'm not going to talk about detox. It's really not a topic, but I'll just leave you with detox is not a treatment. It's not a cure. It's just to get to the person to the point where they could actually participate in treatment. There are pharmacologic therapies available for treatment of addiction, and there are FDA-approved therapies for alcohol, opioids, and tobacco, and there's a lot of work on treatments of other substances. And there's a lot of psychosocial treatments, and I'll leave you with the thought that without psychosocial treatments, we really can't change those circuits in the brain that have been deranged by substance abuse over time. And it can take quite a bit of time, as we've heard, to change things. So here are a list of some treatments, and I'm just going to dive into talking about medications. So this is probably one of my most important slides. So if we were going to design a medicine to treat addiction, what would we do? Well, we could prevent the drug from entering the brain, and that's the theory behind the work on vaccines. So if a person injects a drug and you've made antibodies to the drug would get bound up immediately and would never get to the brain. So that would be a great preventive way to prevent addiction. So there's been work on a cocaine vaccine and nicotine vaccine. And so far, nobody's been able to develop something that really has enough antibodies at a high enough level to really work. But very interesting theory. Aversive response to the drug. So many people in the legal system are familiar with Disulfiram or antabuse. You give it to the patient. They drink on it, they get sick, and the theory is they won't drink on it. We'll talk about that a little bit more. Things that mimic the actions of the drug. So we heard about things like methadone and buprenorphine, but also nicotine replacement. So don't forget, even though tobacco, it's not illegal to use tobacco by any stretch of the imagination. It is actually a huge problem still in the United States and worldwide. It's a huge global health problem. So nicotine replacement basically mimics the action of the nicotine. We can block receptors. So I've heard about antagonists, Naltrexone, and we have agonists such as methadone and buprenorphine. And we can support patients' abstinence. So reducing craving is one way. And we have some things that will reduce craving. Let me get out from under back here. So things to reduce craving include things like naltrexone, and I'll talk about how that works, and nalmefene, which I don't think has made it to the market in the United States. It's on the market in Europe, which is kind of an interesting way. People think they want to drink, so they take some nalmefene, and it reduces their craving. And then reducing risk factors for relapse, such as treating what's called post-acute withdrawal, treating psychiatric disorders, and treating pain, which can be triggers for people. So available treatments, again, the ones highlighted in yellow are things on the market, and a lot of work on stimulant and certainly these days in cannabis abuse, which I think, unfortunately, we may see an explosion of cannabis use disorders nationally with legalization. So I'm going to talk about alcohol first. Might be the easiest one. So we have Disulfiram. The problem, even though Disulfiram, everybody's heard of antabuse, everybody thinks it works. If you actually look at the studies, all the studies on antabuse are pretty inadequate. And there isn't really good proof that antabuse works. And it definitely is not good proof long-term that antabuse works. There is potential morbidity and mortality if the patient consumes alcohol on antabuse, and especially if you have a fragile, medically ill person, this can be a big problem. Potential for interactions with other drugs, and can exacerbate comorbid medical conditions. So those of us who work with patients often are very hesitant to use antabuse. I personally have treated patients who've had some very major life-threatening problems, and even when they weren't drinking on the antabuse. Naltrexone, oral naltrexone is an anti-craving drug, blocks dopamine receptors in the reward pathways in the brain. Oral naltrexone has potential hepatotoxicity. Actually, the long-acting IM naltrexone does not have that black box warning. It's metabolized differently. Acamprosate, probably many people have never even heard or seen anybody on this drug, but again, it has a modest effect. It does need to be dosed 3 times a day, and it's pretty expensive. So a lot of people say the biggest side effect from acamprosate is poverty. So a few words on antabuse. So this is how antabuse works. This is how alcohol is metabolized, and antabuse basically blocks the second step in alcohol metabolism, this alcohol dehydrogenase step, or aldehyde dehydrogenase step. So basically what happens is there's buildup of acetaldehyde. That's what makes the person sick. So this doesn't even, so people get nausea, vomiting, flushing, sympathetic hyperactivity, palpitations, headaches. Some patients really like this. They get kind of high on it, and some people, it is aversive for some people. So this is used a lot in the legal system where it can be monitored, because antabuse doesn't work if the patient doesn't take it. And my patients, you give them a prescription for antabuse, well, they might take it, they might not take it. But if it's, court ordered, then and somebody's monitoring, it probably does work somewhat better. Unfortunately, once the patient stops the antabuse, and people just want to drink, they'll just stop their antabuse. So the efficacy is pretty limited if it's not monitored or if you don't have a highly motivated patient. Some patients are very motivated and they really want to take it, and it works. It does work for them. Studies, again, are lacking on antabuse. Naltrexone, again, it's an opioid antagonist, but the way it works is by blocking the opioid receptors on dopamine-releasing neurons in the reward pathways, and it does decrease craving. The effect in real people seems to be split between the people where this is absolutely miraculous and people where it doesn't work at all. Some people will say, yeah, I took naltrexone and it was great. I had no craving for alcohol. Other people, doesn't work that well. Probably the best evidence in the literature is for naltrexone, and the best evidence is for the long-acting IM naltrexone. So it's probably a really underutilized treatment. Side effects, nausea, and the oral form hepatotoxicity, which personally I've never seen, but it scares a lot of patients away. And when you kind of confront them, well, drinking is bad for your liver too. But I have a friend who tried to do a study with naltrexone in patients with liver disease, and they were so afraid of the liver problems from naltrexone, he couldn't recruit for this study. Acamprosate, I had a slide I took out, it was kind of complicated, had great pictures, but the exact mechanism's unclear. But it's thought when people come off alcohol, they feel bad because of excess glutamate, and now acamprosate somehow balances all that out, and people don't feel so bad. Again, the effects of acamprosate are pretty modest, and in some studies didn't really separate from placebo, especially in US studies and European studies it did. Probably different patient populations were being looked at. In my experience, it's pretty well tolerated, okay to use with people who have liver disease. If they have renal disease, reduce the dose. I've had patients who thought this was pretty good and they were able to take the 3 times a day. In certain areas of the country, I'm told it would never be accepted because the dose is 666 milligrams 3 times a day. So if you're Catholic, forget it. So I had a fellow who was from Miami. She said, no way. But it does have modest effects. Again, if somebody asked me, it's like, well, if it's my family member, sure, I would use these things. Why not? Give it a try. But again, it is pretty expensive. And a lot of other things have been studied with varying success. I won't go into all of these. Okay, tobacco. Not really a legal problem, but big global health problem. So I'll just spend a few minutes talking about tobacco. So we have nicotine replacement. We have Varenicline, Chantix, and we have Bupropion, also known as Wellbutrin or Zyban, are the three things available. So nicotine replacement is first line, doubles the success rate of placebo. The spontaneous quit rate for, you tell your patient, stop smoking, it's bad for your heart, it's bad for your lungs, it's, you're gonna, all the health risks, well, 5 to 10% spontaneous quit rate per year. Pretty abysmal. Nicotine replacement alone will double that. And many of these agents are over the counter. They don't require a prescription. So patches, lozenges, and gum, patient doesn't even need a prescription. They don't even need to talk to any of us about it. The nasal spray and inhaler are by prescription. And the patients kind of choose what they want. Heavy smokers may need a patch and gum, patch and lozenge. So I won't go into, but really, this works. Bupropion, thought to block dopamine norepinephrine receptors, antagonizes nicotine receptors. It can be used first line. You can combine it with nicotine replacement, has some side effects, nausea, insomnia, anxiety. There have been some genetic studies. There are certain populations of people where bupropion is highly effective for smoking cessation, but we're not at the point where we do genetic testing yet. But it is an effective treatment and can be combined with nicotine replacement. Varenicline is Chantix is very, very effective medication for smoking cessation. So it's a nicotine receptor partial agonist. It is also first line. It definitely reduces cravings, blocks reinforcing of smoking, and has very significant improvement of quit rates over placebo. It's better than bupropion. It's better than nicotine replacement. It does have some side effects, and there is big literature about whether it causes psychiatric side effects. It had a black box warning, which was recently removed, which is good news. Hopefully make people more comfortable using it. But nausea, insomnia, and then the neuropsychiatric side effects. So I would say, patients who have, bad mental health issues, you put them on Chantix, you want to monitor them closely, but for most people, they're going to be probably fine. So opioids. So this is the big subject, and I've been set up greatly so I don't have to talk so much about opioids. Okay, but there's a lot of legal issues in treating opioid addictions. So long ago, over 100 years ago, we had the Harrison Act, which basically prevented physicians from prescribing opioids to treat addiction. So that made it pretty hard to treat anything with medications. In 1970, which doesn't seem that long ago, it took until 1970, Controlled Substances Act. So in response to that big heroin epidemic in the 60s, methadone clinics were established to treat heroin addiction in the 70s. And then buprenorphine was known for many years before the Drug Treatment Act of 2000, which actually allowed people to use buprenorphine to treat addiction. And gradually, use of buprenorphines become a little bit easier. So buprenorphine's on Schedule 3, makes it a little easier to use than methadone. You use it in your office. Originally, people were limited to 30 patients, then it was expanded to 100. And the Comprehensive Addiction Recovery Act of 2016 expanded that to 275. I think that was in that piece of legislation. And shortly, prescribing will be extended to physician assistants and nurse practitioners, not just to physicians. When I took my training for buprenorphine, because you have to take a special training to prescribe buprenorphine, it was pointed out by the trainers that this is the only drug on the market that requires special training to prescribe. And it's probably not the most dangerous substance on the market by any stretch of the imagination. So I'll just leave you with that thought. So how do we treat opioid dependence? We have methadone. Everybody's heard of methadone. We used to have LAM, which is a long-acting form of methadone. That's not what it stands for. We have buprenorphine, which can be used alone or combined with naloxone. And the combination with naloxone is thought to prevent abuse. And we tend to use buprenorphine alone in pregnant women and in people who can't have some allergy or adverse effect to naloxone. But usually use it combined with naloxone. Because if you inject your buprenorphine, then theoretically it won't work if naloxone, an antagonist in there too. I'm not sure that's true. And we have naltrexone. So you saw this in a different slide. Basically, you have a full agonist like heroin, methadone. You use the drug, it binds the receptor, you get a big effect. You have partial agonists like buprenorphine, it binds the receptor, you get an intermediate effect. You have an antagonist, it blocks the receptor. It doesn't do anything, but you put other substances in there that bind to those receptors, they don't do anything either. It's the simple discussion. So why do these agonists work? Is it like the person's just using a new drug on top of, they were using heroin, so we'll give them methadone instead, they can use methadone instead? Well, people do not get high from buprenorphine and methadone. It seems there are a lot of derangements in the opioid receptors that are, this is my very simplistic view and explanation. There are derangements in the pathways, derangements in the receptors, and the agonists seem to fix those derangements, so the patient doesn't feel bad. You take heroin or other opioids away from an addict, they feel bad, and they feel bad all the time. And it seems like using the agonist really corrects that problem for them. So because of all the legislation, you can't just give it to anybody who's using opioids, so they have to have a diagnosis of an opioid use disorder. I won't go into how you do that. And they have to fail abstinence-based treatment first, usually. That's getting loosened up a little bit too. Naltrexone's an antagonist. Again, comes in oral and injectable forms. The same stuff we use for alcohol use disorders. It's a deterrent. And this I get, for those of you who work in the legal system, probably see this a lot. Persons in addict or they're trafficking drugs or whatever the problem is, and you put them on naltrexone so they don't use. Of course, if you put them on oral naltrexone, like hopefully they take it, but if you can put them on the long-acting IM. This is not preferred by most patients, and most patients, as soon as they have the opportunity to stop naltrexone for opioid dependence, they will. And if you offer it to people in the community, I have yet to have a taker who wanted naltrexone versus something else. People considered it, but they always came back and said no, they want buprenorphine, methadone instead. So methadone's a full agonist, and I'll not go through this slide, but it's limited. It has to be given by a licensed program, can be given for pain if there's no chemical dependency. That's kind of a muddled area. And severe limitations on use of methadone for methadone maintenance. And there are just not enough methadone programs. But in order for methadone to work, you just don't give the patient methadone, you have to give them enough methadone. So typically we need doses over 80 milligrams a day, which is way more than preventing withdrawal. And people need counseling, medical services, ancillary services, education, vocational rehabilitation, a lot of things they need to do to change their lives to really, for methadone to work. So next question, does it work? It definitely works. Decreases heroin use, increases employment, decreases criminal activity, people stay in treatment. Also increases health outcomes. You have less people getting hepatitis C, HIV, tuberculosis, and other infections. It is very cost effective. There were multiple studies on whether methadone is cost effective. It's definitely cost effective. So methadone definitely works. If you work in psychiatry, the best evidence for efficacy of treatment are antipsychotics for psychotic disorders and opioid replacement for opioid use disorders. Buprenorphine can be prescribed in an office-based treatment, doesn't have to be a specialized program. People do have to have special training. You have to be a qualified practitioner, so now you have to be an MD, a physician assistant, or a nurse practitioner, and you have to take the training. You have to be able, you don't have to have counseling in your office, but you have to have somebody who will see your patients if they need counseling. And the maximum number is now going to be 275. I don't know if that's implemented as yet. I don't know anybody who has that many buprenorphine patients. So outcomes are very similar to methadone, and it seems to work very well. And for those who are interested in women, works very well for pregnant women as well. Stimulants, I have a couple slides on stimulants and cannabis. So lots of studies, people have looked at agonists, try to give people other stimulants, use cocaine or meth, give them some, prescription. Amphetamine, well, that's had mixed results. Tried antagonists and tried things that decrease, and we've heard about stimulants cause release of dopamine, so we've tried dopamine agonists and dopamine antagonists. So here are some examples of what these things might be. And also, we mentioned vaccine. And a lot of other things have been studied. So the bottom line with stimulants is that thus far, nothing works very well. Still looking for the right medication. I know that a lot of researchers at OHSU and elsewhere are looking very hard. There's some promising things out there. Cannabis, so far psychosocial treatments are pretty much the mainstay. There have been a few studies using N-acetylcysteine, which is available over the counter. It's an antioxidant. There was one study in adolescents which looked pretty good, but that's really the only thing right now that's known to have had any efficacy in studies I'm aware of. So that's actually my last slide is, what are the barriers to use? We have legal barriers. We have a lot of barriers with regard to prescribers, and prescribers need to be knowledgeable about these things. They need to accept them. Patients have to accept them as well. That's another problem. Cost can be, somebody was asking me about, well, one shot of IM Naltrexone could be $500 a month. And so that's a barrier. Traditions. I mean, a lot of traditions in the A and NA community where people didn't take medications. I think that's being broken down. And resources. Certainly, Comprehensive Addiction Recovery Act of 2016 is very ambitious, but is the funding going to follow? So we have a lot of things to think about and overcome. So thank you.